All right, so it's 9 o'clock. Welcome all to this educational event hosted by the Department of Neurosurgery, University of Pretoria. I must firstly acknowledge the support from Europa Organization Africa, particularly Yoshni and Claire, for all the logistics support, and Life Healthcare for assisting in making this quite a seamless endeavor. So firstly, I'd like to thank all of you, our attendees and esteemed faculties, for taking the time to attend, especially during these challenging times. It's perhaps more evident now than ever before that we need to dramatically improve the way we see, interact, and treat each other as fellow human beings. And this Pediatric Neurosurgery Symposium, which forms part of our Safe Neurosurgery initiative, which we aim to run as a series of webinars. Likely moving forward, we will move this time slot to the evening, I think, as most of us are getting back to a normal schedule that might make more sense. So this is a particularly special feature, as it marks our first Van Rensburg-Mokokong Oration. And as you will hear, Professors Van Rensburg and Mokokong were both previous heads of this department. And this forum gives us the opportunity to celebrate some of their achievements and contributions. I must also thank the Van Rensburg and Mokokong families for supporting this, particularly Professor Mokokong himself and Professor Van Rensburg's son, Martinez. So we'll hear more about these titans of South African neurosurgery, their remarkable contributions to our speciality when they're formally introduced later. But briefly, Professor Van Rensburg during his era, I think, was largely regarded as one of the best neurosurgeons South Africa has produced. He was adored by those he trained, and we will hear more details from one of his proteges, Dr. Duplessis, a little later. Professor Mokokong then succeeded him and steered the department through quite a challenging transition period. Professor Mokokong is a highly respected neurosurgeon with special interest in neurocritical care, and famously was involved in the craniopagus twin separations in South Africa. And true to form, still continues in an extraordinary capacity to serve and treat patients even post-retirement. And we'll hear more details about him as well from one of his proteges, Dr. Tobajani. So in an effort to set the tone, I'm going to stick to my allotted time allocation, and I will then introduce our first speaker, who's Professor Isel Smuts. So Professor Smuts is a pediatric neurologist, head of the Pediatric Neurology Unit at the Steve Biko Academic Hospital. She was appointed as a pediatrician in the Department of Pediatrics at the University of Pretoria in 1997, was responsible for the development of the Pediatric Neurology Unit, which was one of the first training units in the country at the time, now providing a service to upwards of 6,000 patients per annum. She completed a PhD in biochemistry. Her research focuses on mitochondrial disorders in the South African context, several publications in this area. Prof. Smuts and her team manage the entire spectrum of pediatric neurology and neurodevelopmental disorders. They also initiated quite a novel transitional clinic, which I think we as pediatric neurosurgeons would value, transition from sort of pediatrics through the adolescent period into adult care for chronic neurological and neuropsychiatric conditions, including both adult neurologists, psychiatrists, and their parents, who all benefit from this. So it's a great pleasure for me to introduce Professor Smuts to give a talk. Thanks.
Good morning, everybody.
Isel, are you able to share your screen?
I hope it's projecting now.
Yeah, there we go.
Is it projecting?
Yeah, it's projecting. Just sort of click on the play so that it enlarges.
Okay.
Okay,
Can
thanks.
you see everything?
Yep.
Good, perfect. Noelle, thank you very much for the invitation to participate in this webinar. It's really an honor and a privilege to be part of this initiative. And I hope that we are going to make a huge difference in future as well for our children. Children differ from adults. They are extremely unique. And therefore, we cannot apply everything that we were taught in the medical school, how to examine a person, and how we were taught for adults, we cannot apply that directly to children. And the reason for that is the entire concept of development. Now, the development reflects in the milestones that we see, including the gross motor, fine motor, psychosocial and language developmental skills. And of course, due to the age linked to the development and the milestones, we will have unique findings in every and each age group. So we have to be very, very creative in examining these children and assessing these children. So the principle here is definitely to stop, look, and listen. First impressions are more important than ever before. You have to create your own view of the mom and the child, or the dad and the child, the moment they enter your room. And then you have to make sure that you collect all the puzzle pieces and eventually make a diagnosis. So the reason why we have to take all these things into account is because abnormal structure results into abnormal development. And we, of course, need to make sure what is the parent-child interaction and the emotional well-being and motivation, as it plays an enormous role in the success of treatment of these children. We're going to embark on a road trip, and we need to understand where everything starts, how to figure it out, and I'm sure that we all have traveled this very difficult gravel road full of potholes. Sometimes we get to a diagnosis and then we're very happy, because then we can actually try to manage the patient appropriately. Everything starts right at conception, and there are a number of events that lead to the full development of an adult. So initially, we are all familiar with the process of neurulation, where we have the formation of the neural tube together with the closure of the neural tube, and then the front part of the brain that start to develop cross-encephalization to form the hemispheres and related structures. But this structure needs to be populated by neurons, and the neurons differentiate at an enormous pace. That starts around about 8 weeks up to 16 weeks of gestation. The neurons then migrate, and it's exactly like a climber in your garden growing up against a trellis. The neurons then proliferate, migrate, mature, and start to differentiate into different cells. The whole process also contributes to the formation of the sulci and gyri. Then organization needs to take place, because the cells can't just grow like plants in your garden. It has to be organized. And then a number of processes, including alignment, synaptogenesis, apoptosis, will lead to an eventually well-connected structure in the brain with numerous neural networks. The process of myelination then follows. It starts around about 28 weeks, carries on up to early adulthood. And this is the major determinant in the development during these phases. Also contributes to the weight of the brain. So, the risk factors. There are so many delicate processes happening during the entire development of the nervous system that any risk factor may have a serious influence on the outcome. And these risk factors already start preconception. Poor maternal health is extremely significant in this whole process. Epilepsy, and not only epilepsy and the drugs that mothers may have, has a serious influence on different stages in the developmental process. And of course, genetic predisposition plays an enormous role. During the pregnancy, the in utero environment is supposed to be a very safe environment for the fetus to develop. But once again, poor maternal health and toxins like alcohol, medication, drugs, antiretrovirals, infections can influence the different episodes and the different processes that take place during the antenatal period. I think we are all familiar with the postnatal problems that can arise and influence this process, of which environmental factors are well known: infections, meningitis, HIV, tuberculosis, trauma is not uncommon in our situation. So when things go wrong during the neurulation phase, we get the entire spectrum of neural tube defects, and it can range from an encephalocele to a complete open spinal cord. Prosencephalization follow. So if the forebrain is not properly formed, you can get hydrocephalus or a spectrum of holoprosencephaly. This is a less severe form where we have lobar holoprosencephaly. Parallel to this, the hindbrain also starts to develop, and the cerebellum, and we are well familiar with the entire Dandy-Walker and similar kind of syndromes. Then, around about the end of the 8th week of gestation, the choroid plexus and ventricles start to form, cerebellum continue to form, and neurosurgeons are well familiar with hydrocephalus and the management. I already mentioned that neuronal proliferation is very important to populate this entire structure. So if there's too little growth or too little proliferation, we will get microcephaly, or an overgrowth will lead to macrocephaly. And then, once again here, microcephaly, all the teratogenic factors that can influence the processes. Macrocephaly, we're all familiar with neurocutaneous disorders and the associated central nervous system involvement, neurofibromatosis, Sturge-Weber, with all the vascular abnormalities, tuberous sclerosis, and many more. Then the migration process is important for the development of the salsa and gyri. So the worst form here can be then lysencephaly, less severe, where you have abnormal macrogyria, and then conditions like schizencephaly. Heterotopy are very important in some difficult to treat epilepsies that can be treated surgically. Organization cannot be seen on neuroimaging. It's on a molecular level. And the alignment and synapse formation and apoptosis, when things go wrong there, we will end up with conditions like autism, schizophrenia, and many more psychiatric conditions. Myelination and abnormal myelination is something that the pediatric neurologist may see more than the neurosurgeons. This is an example of periventricular leukomalacia associated with premature babies. And then we deal with many other conditions where there is either dysmyelination due to inborn errors of metabolism or destruction of the myelin, like autoimmune encephalitis and many more conditions there. After birth, tumors, infections, trauma, and stroke are well familiar to you all. We've got tumors, hemorrhages, infections, strokes, vascular abnormalities. But we are clinicians and we need to make a diagnosis. So how do we get to a clinical pathological diagnosis? First of all, we have to examine the child. And once again, it differs from an adult. Then we have to bring everything together to ultimately get to a diagnosis. So the child must definitely be examined from top to toe. And this is the collection and finding of all the puzzle pieces. We know that there are unique age-related findings. In babies, responsiveness and attentiveness and response to the environment is extremely different and completely different from a bigger child. For us, it's extremely important to know the older children's way of perception, mathematical skills, as it has an influence on the drugs we choose and the way we manage the patient. So one of the other unique findings that we have in children will be consciousness. It's not so easy sometimes to determine the level of consciousness in a child. So we know that we have to use the modified Glasgow Coma scale. And for us, it helps to think about crying as one of the responses to determine the best verbal response. Synthesis and integration is really building the puzzle so that we can ultimately get to the site and extension of the lesion, get to an idea of the etiology, determine the degree of illness, and then the complications, not only of the underlying disease, but also of the drugs and other management modalities that might have been used. So we are all involved in the medical treatment and then the surgical treatment, and epilepsy is one of the big areas where there's enormous overlap. I just have to mention the medical treatment of epilepsy in children, and the drug choice that we make depends on the age. We cannot use all the drugs for every child. The seizure type, the dosage according to the weight. Then we have to take the cost, the availability, and the patient into consideration. Difficult schedules of drug administration is sometimes really not the way to go. The type of drugs that we use must be used sensibly, also according to the family, the child, the condition, the underlying condition. We can see that the cleanest drug is gabapentin because it doesn't have a lot of effect on the higher functions. But it's not so really used in pediatrics. Phenytoin looks very bad, and we never use it for a chronic kind of treatment of epilepsy, but we all know the value and status of epilepsy. Everybody shies away from phenobarbital, but in some patients where we have a minimal conscious state, cerebral palsy patient with a gross motor 5, max 5, and communication 5, phenobarb is ideal. Make sure that the drugs that you choose very often is appropriate for children. Valproate, carbamazepine can have a serious effect on the learning process. I've already mentioned the different conditions that we neurosurgeons are involved in and well familiar with. In addition to that, I just want to mention that deep brain stimulation is important. We've got a number of patients that benefited from that. So, children are unique. They differ from adults. And everybody thinks about personalized medicine as something for the future, something very costly. But in our little world, we can already apply personalized medicine by taking the age into account and how to deal with a specific situation. And I think we all have the wonderful opportunity to make today matter. And that is also the motto of my team, and it's the motto of the Faculty of Health Sciences at our university. Thank you.
Okay. So thanks very much, Isel. Can you hear me?
I can hear you, yes.
It was a real masterclass on what pediatric neurosurgeons and neurosurgeons in general need to know about pediatric neurology. I'm going to introduce our next speaker, Professor Uli Tomale. So Professor Tomale is Chief of Pediatric Neurosurgery at the prestigious Charité University Hospital in Berlin. His special interests include the treatment of hydrocephalus, in particular neuroendoscopy and navigation guidance. He's published extensively on these and other neurosurgical topics, is frequently invited speaker at numerous international neurosurgery congresses. He served in various executive roles in many international and national German national neurosurgery societies, including the ISPN, ESPN, and the IFNE, where he's lead investigator for the Trophy study, evaluating the management of children with intraventricular hemorrhage and hydrocephalus. So it's a real personal pleasure to welcome Professor Tumhale, who will give us an overview of hydrocephalus, its management, advances, and adjuncts. Thanks, Uli.
Thank you very much, Gwelin, for this very kind and almost overwhelming introduction. Thank you very much. And it's a great pleasure and great honor as well to join this very nice endeavor of education on a very high level. And it will be a pleasure for me to talk about the management of hydrocephalus in children, advances and adjuncts. I'm sure that you will understand that I will tell about the German perspective and how we deal with hydrocephalus here in Germany as well. First of all, according to pathophysiology of hydrocephalus, Harold Recade made this very nice picture of to make understand that CSF is not alone. It's influenced by blood inflow, it's influenced by a CSF production, then the CSF major pathways from one ventricle to the other, the CSF resorption at the overlap towards the capillaries and the veins for outflow, as well as the intraparenchymal pathways and the venous congestion. All these factors are involved if hydrocephalus occurs, and this is something we have to keep in mind. And for each specific case, it's not only like an aqueducted stenosis, there's one pathology. Maybe there are several others, like in plexus papilloma, in hematoma, or in spina bifida patients, where you have different of those factors of pathophysiology involved, which makes hydrocephalus a more or less complex disease, more complex than we often think of. When I talk about treatment of hydrocephalus today, I will not talk about intermittent treatment like putting reservoirs or EVDs or endoscopy, because this will be the context of the next speaker. I will mostly talk about shunts. And shunts is not the biggest friend of a neurosurgeon, since we know we have a lot of struggles, we have a lot of pain with it. However, if we look back in history, since 1956, it was developed by the group in the United States, also initiated by Eric Holter, whose kid had hydrocephalus. If you look at the period before that, we had a 70% in Germany of mortality, and most of the children actually had severe disability, and only 4% are documented to be healed. This is a series which can you see from the Charité from this period of time. And after the shunt was introduced, actually the mortality rate due to hydrocephalus completely dropped down, which makes maybe the shunt as one of the most successful treatments in neurosurgery. And this is something we always have to keep in mind if we do a shunt surgery. Everybody does shunt surgery differently, and you can debate about every step. This is how we do it, and it should go fast normally in the operation room. So in a protocol, we do a frontal entry site for the catheter, we do a burr hole reservoir, we put a valve behind the ear, and we do a paraumbilical incision right next to the belly button. We use trocars in order to tunnel from one incision to the other. If you see here, this is a small video how we place the subcutaneous catheter. The precondition for putting a shunt is, first of all, the indication being mostly a communicating hydrocephalus, in contrast to non-communicating hydrocephalus, where endoscopy plays a bigger role. It should be clean CSF with a normal cell count and the protein level, which we use a threshold of 2 grams per liter in the CSF, and the body weight in our unit is the threshold of 2 kilograms body weight before we put a shunt. This is how it looks like after surgery. if we compare also VP shunts, are the most commonly placed shunts in neurosurgery. Historically, there have been different cavities described in the literature where you can put shunts, but VP shunts are accounting for maybe 98%, and VA shunt is our second solution if, for whatever reason, the peritoneal cavity is not feasible to put the shunt in, so it accounts for 2% to put a VA shunt. This 2% is still a number where we should know how to place it, and we use a Seldinger technique in order to use ultrasound guidance, puncture the jugular vein after placing the proximal parts. Then we use X-ray in order to put a wire into the atrium, and then a peel-away catheter is used in order to place the distal catheter into this peel-away catheter right here, and then check on X-ray again that your tip of your atrial catheter is just in the level of the atrium. Putting shunts is one thing, and avoiding complications which can occur right after surgery or in the long run is the other thing, which is maybe the biggest challenge of us neurosurgeons. And there's infection, which need to be addressed. There's obstruction. There is multiloculation after infection or bleeding, malpositioning of any kind of shunt particles, and then overdrainage and underdrainage, where different adjuncts can be used in order to titrate the CSF drainage through the shunt appropriately. First, infection. The most important thing to address infection is having a protocol, having an experienced neurosurgeon who knows the step from sleep and uses a lot of different things like single shot antibiotics 30 minutes before skin incision, skin cleaning, then another skin cleaning and disinfection after the surgeon has scrubbed in, tight draping, glove exchange, limited traffic to the OR, limited handling of the implants, and incision away from the valves. Antibiotics can be used either integrated in the catheter, or sometimes we use also vancomycin bath, where we put our catheters inside before we implant them. Antibiotic catheters have been addressed in a big prospective multi-center randomized trial, which was performed in the United Kingdom. And they have actually showed that they were able to reduce the infection rate from 6% to 3%, which was also more pronounced in the pediatric cohort. However, these antibiotic integrated catheters had a seemingly higher revision rate due to other reasons, which made the total amount of revisions similar to the other groups. However, infection is definitely the worst of all. What about obstruction, which we normally observed after bleeding or infection, for example? We introduced neuroendoscopic lavage in 2010 in our department, which was primarily invented by Sergio Caballero. And he was using it in intraventricular hemorrhage in newborn babies, specifically also in premature babies. And the endoscope is used in order to irrigate inside the ventricle, have a passive outflow and an active aspiration in order to approach the clots. And you can see here different stages of bleeding where the surgery was taking place. Here you see the black plaques on the ependuma, a later stage where the surgery took place compared to the upper video. We approached the lateral ventricle in order to clear the lateral ventricle from the blood, and then we use we also approach the third ventricle. This is done under ultrasound guidance, and here you can see the different steps. First, it's just foggy, then it becomes clearer over time. This intervention made it possible actually to reduce in our cohort the amount of shunts which needed to be placed from 100 to 60%. And we also reduced the infection as well as the amount of multiloculated hydrocephalus. Since we have only published a bi-center study experience until today, we have the big endeavor together with the International Federation of Neuroendoscopy to prove different concepts of treating intraventricular hydrocephalus in the Trophy Registry study. And you are very welcome to join going to the website trophy-registry.org in order to join this endeavor. Infection and especially ventriculitis is another thing where we can use a neuroendoscopic lavage. This is a very premature baby with sepsis of staph epidermidis and serratia meningitis. Here you can see the pus, which is aspirated through the endoscope, and then over the time the patient needed to have a shunt. Most of those patients with ventriculitis are in the need to have a shunt. Only 8.7 in our cohort did not need a shunt. We were able to reduce by neuroendoscopic lavage the amount of pus and as well protein and cell count. And more importantly, using neuroendoscopic lavage was reducing the shunt revision rate and the shunt reinfection in the long run, which made it quite an advantage procedure. Placing the ventricular catheter is an easy thing for every neurosurgeon. However, it goes wrong in some of the cases, reported in the literature between 12.5 to 44%, documented, and we try to use as often as possible a guidance, which we can do with the smartphone app and this little guide instrument, where we adjust the coronal plane trajectory towards the skull surface, which can be measured accordingly on the coronal picture on a smartphone application. You can see the 7 degrees of tilting the instrument medially, which can be applied to the patient, and then the catheter can be placed through the guide into the ventricle. This is the intraoperative view, how it looks like if we use this little instrument, which makes the whole procedure as fast as a normal catheter placement. We have done a prospective randomized trial in Germany, and we could see that 100% of the catheters with a guide were placed with a first attempt, and the amount of malpositioning reduced from 31% to 10%. And those 10% were either too short or too long, but not wrong by direction. The other thing is overdrainage or underdrainage. Therefore, we have to understand what are the forces of CSF draining through a shunt system. And here we have the intraventricular pressure and the intraperitoneal pressure, as well as the resistance of the valve and the shunt itself. However, in the upright position, the hydrostatic pressure comes also in place, which is here the example if somebody pushes air into a tank and have another tube which goes all the way down, and the hydrostatic force is now enabling to let the fuel running out of the tank of the car into an outside tank. And this happens to the shunt as well. If we don't address this, we have constant overdrainage, and this is something we need to overcome by, for example, gravitational units. Also, we have to address that different forces are related to shunt drainage. It's the underlying disease, it's the size of the ventricles, it's the activity and the body weight of the patient. And the problem is that there are chronic changes, which translates into anatomical changes like proximal occlusion, slit ventricles, bone hyperplasia, or microcephaly, which can be nicely seen in this patient, 6 years old and 19 years old, very small cavity for the brain, slit ventricles. And this condition needs to be avoided at this stage and not at this stage while the child is still growing. So we have to increase the resistance of our shunt systems and especially of counteracting the hydrostatic forces, which can be done by gravitational units. This was a German multi-center observational study where the first PDGAV was investigated with reasonable survival rates of the shunt itself as well as the valves. And these gravitational units are also achievable by low cost. For example, the Shabra hydrocephalus shunt, which costs normally 50 euros, also offers a gravitational unit, which can also nicely, as investigated by Chosnica and the Cambridge group, the hydrostatic effect accordingly. So it can be used in any case. Adjustability adds some further advancement. We had a lower revision rate of almost 10% of the valves after 2 years. So using adjustable valves, I think, is something we have to acknowledge as a treatment option. And we have to look in the literature how those adjustable valves work and to pick the right one which you think. What is the advantage of adjustability? And adjustability is something you don't necessarily have to put in the valve itself. You could also think about revising the shunt and putting a higher resistance over time. But you can improve clinical symptoms, you can adjust the head growth of the patient to a normal level, and you can avoid split ventricles by increasing the size of the ventricles itself. We do sometimes some adjustability also for the gravitational unit in the upright position, which can be adjusted by this PROSA from 0 to 40 centimeters of water column. And in our protocol, we need maybe those kind of adjuncts in 10 to 13% of our cases. And we just put this further adjustability in between the other two compartments. The newest development is telemetric ICP measurements of the shunt itself. So we are able to measure through the reservoir of the shunt system the intracranial pressure in different body positions like lying, sitting, or standing position. And then we are able to readjust the valve system in order to have a more physiological condition in the shunted patients. Our first experience was just published in Acta Neurochirurgica in 2020, and there we could see that from not a lot of patients, but still the majority could be improved by the clinical symptoms. And mostly we had to adjust it, actually the gravitational unit more upwards and the differential pressure unit more downwards, which I think is interesting in terms of what is important. They're different of those telemetric ICP sensors on the market, which we also compared in this study. At the end, I would like to stress that there was still the major opinion, which is based on the Drake study from 1998, the last randomized trial where only 3 different valve types were compared. And then the published paper from John Kessel from last year in Journal of Neurosurgery Pediatrics. He states there was no significant difference in the times to shunt failure in this 1998 study, a finding that has led to some readers to the conclusion that valves are all the same. This is an oversimplification because many other valves on the market have not been assessed in this way. And this includes also the Chabra valve, for example. So I think there's more work to do for the future. We have to acknowledge hydrocephalus is a complex disease. Shunt treatment is relevant. Advancement in neurosurgery. The main challenge in children to avoid complications, being aware of the complications for neurosurgeons is the most important point, being infection, correct implantation, occlusion, and overdrainage. Advancement in shunt technology opens new perspective, but needs further proof of benefit. And the factors, of course, are for decision-making, the experience of the surgeons, the protocol, and the cost, which needs to be adapted to each system. Thank you very much, and especially to Gwelin for inviting me for this very nice webinar.
Thank you very much, Uli. That was just a fantastic overview. Thanks for the effort. And I think after a talk of that quality, we are definitely going to have some questions. So we've got 2, and I think we can make some time quickly. Claire, can you just confirm that the screen is sharing correctly?
Yes.
Okay, is our holding slide sharing correctly?
If you can just, just make it as a preview. There you go. And it's sharing correctly.
Okay, great. So 2 questions. The one is from Shlomi Konstantini. Shlomi, I'm going to get you to unmute yourself and ask the question yourself.
Yes. Hi, Uli. Thank you very much. My question is about VA shunts and ventricular pleural shunts, especially in infants where we are stuck with the abdomen and lavage and CPC doesn't work. What is your lowest VA shunt or ventricular pleural shunts?
So I have to be honest that we have never made a ventricular pleural shunt, and maybe we have to be fortunate that we were not forced to do one until now. So I don't have any experience with ventricular pleural shunts at all. The VA shunts, actually, we have one patient here in our ward at the moment, which is a premature baby, and we put the VA shunt at the same threshold where we put the VP shunts. It's 2 kilograms. And in those children, you just have to be aware that you have to change the distal catheter at an earlier stage because they will grow out the distal catheter. Maybe you can place it then later on as a VP shunt, which we always try with the help of laparoscopy.
Thank you. Thank you.
Okay, we've got 2 more questions. I'm going to try and get to both of them. The one is from Ro Harichan Prasad. Ro, you want to unmute yourself and ask the question?
Sure. Thanks, Llewellyn. So it's a very interesting device that for the shunt placement using the cell phone and the instrument that you described. I haven't seen it before. Firstly, I mean, is it freely available? Where can you get it? But the question I wanted to ask is, should some form of intraoperative navigation be used for all shunt placements?
Yeah. First, to your second question, of course, there are different options. There's ultrasound if the fontanelle is open, for example. There's navigation, which is also very nicely feasible and has been proven in the literature. However, you need to have more like technical, sophisticated stuff in the operation room in order to perform this step of ventricular puncture. Our device is available here from a company which is just close to Berlin. And it can be bought as in countries where the CE mark is applicable. The application is only available for iOS, so for Apple. It's in the App Store, and this is for free. To be honest, when we started, we did not need the instrument itself. We just looked at the screen and we took sterile paper and just cut the angle on the paper and just applied it to the patient as well. So there are very, very cheap possibilities to just apply the same technique in patients as well.
Thanks very much, Uli. Perhaps we'll just take one more question, well, 2 if we can get to it, from Wei Lun Lee. Wei Lun, you want to unmute yourself and ask the question?
Hello, hi, very nice presentation. May I know for pediatric VP shunt, what is the location of choice, whether it's frontal or parietal? Let's say for congenital hydrocephalus. Just now, Prof. Mong Gong Kong actually stated that he does a frontal shunt. May I know any particular reason? Thank you.
Okay. Yeah, thank you very much. The choice using the frontal or the parietal entry point is depending on yourself mostly, because the literature does not help in this decision. At the moment in the United States, they're doing a prospective randomized trial, and the results I think will come out in 2021 or 2022 in order to clarify this question. Our protocol is always to put a frontal catheter in all of the cases, no matter what kind of pathology is behind it. So this is our protocol, and we are very strict in this.
Okay, thank you very much, Uli. In the interest of trying to keep to time, I'm going to move to our next speaker. So it's an absolute pleasure to introduce Professor Andre Grotenes. Professor Grotenes was full clinical professor and chairman at the Department of Neurosurgery at Radboud University Medical Center in Nijmegen, the Netherlands. His many training fellowships included one at the Sick Kids Hospital in Toronto. He did a PhD on endoscopic third ventriculostomy in the treatment of hydrocephalus, and recently served as president of the EANS. Also serving on numerous prestigious international neurosurgery societies. He's a prolific publisher with 2 books, 21 book chapters, more than 90 peer-reviewed publications, and over 400 invited international lectures. So truly a giant in neurosurgery. It's an absolute pleasure to welcome Professor Grotenes to talk to us about neuroendoscopy in pediatric neurosurgery. Thanks, Andre.
Well, thank you so much, Llewellyn, for the very kind introduction, and also the invitation to join you with this. Let me see. I hope you can see this now, but I am not sure that I can enlarge it sufficiently. Yes, so that I can start. So you asked me to address the role of neuroendoscopy in pediatric neurosurgery. And that's quite a task for to do so in, let's say, 10, 12 minutes. But the revival of endoscopy in the late 80s of last century was, of course, in pediatric neurosurgery, because still one of the main indications is within the treatment of hydrocephalus. And some of the more current applications of endoscopy have been addressed by Professor Tomale. But inside the ventricle, especially after we have CT and MRI scan, we see cysts and also tumors that maybe can be biopsied through an endoscope. It's rather rare to have a real removal of that. And then we ventured further on to also go a little bit aside the ventricle. So arachnoid and ependymal cysts adjacent to the ventricular system, and also tumors adjacent to the ventricular system. And a complete different way of using an optic or an endoscope is in what is called the endoscope-assisted surgery, which is effectively microsurgery, but also the endoscope is used. And in pediatric neurosurgery, that is mostly for removal of tumors, especially skull base, craniopharyngiomas, but currently also the craniosynostosis, especially the non-syndromal cases. So in hydrocephalus, I can move on rather quickly because you have heard this very nicely in this overview. To treat the obstruction inside the ventricle, obstructions outside the ventricle, and of course, of all those types, you have mixed types, and everything else that is more difficult to treat is called complex hydrocephalus. And if you see that, of course, shunt is still an essential kind of surgery we do when we deal with hydrocephalus in the pediatric age group. But the use of an endoscope should be considered rather frequently, be it with ETV or cystostomies, but also with choreplexus coagulation, as has been shown in the sentinel work of Ben Worf. So third ventriculostomy is the mainstay nowadays in neuroendoscopy for hydrocephalus. It's now a really common procedure to do. But also these kind of cysts that were really tough to treat previously because they are tight and it's difficult to put a shunt inside. We always thought that you were inside that big cyst, but usually only were at the outside of the cyst wall. And these are so-called Mickey Mouse cysts are ideal indications for endoscopy. And as you see, usually the hydrocephalus is not really going down as it is with ETV. And we had to learn that over time. But more important is that you can see here on the right side that the flow through the aqueduct is reestablished while the cyst is collapsing. So that's, and that is a part to avoid shunts in these cases. One other, typically an indication in pediatric neurosurgery, is the so-called trapped fourth ventricle that we see mainly after post-hemorrhagic hydrocephalus, even more than after post-infectious hydrocephalus. So in such a case, we followed over a year the regular MRI scans. As you can see, it's the sequelae of the hemorrhage, and still the fourth ventricle is doing well, so it's shunted. And then all of a sudden with symptoms, at one point you see there is now a fully blown fourth ventricle, a clearly obstructed aqueduct, and also the bulging of the floor of the third ventricle, which point to the fact that we should think of how to treat this. So what is the best to do? So either doing it from above through the ventricles, or you go through the cisterna magna, or even transcerebellar and just place a shunt or try to open the aqueduct through that route. So a very straightforward approach for me is that when the ventricles are large, I use the endoscope through the lateral and then third ventricle, because then you have the option of an ETV. But when the lateral ventricles are very small, I prefer a suboccipital approach that you can see here. It's clearly this thick introduce an endoscope from below, and then you can see here with the balloon opening that and opening the aqueduct, But we also learned that that is never sufficient. You need to leave a kind of stent inside, so a kind of piece of catheter to keep that open. But in this case, it was easy, small aqueductal stenosis and a really wide foramen of Monroe, and that is what you should measure, because this is the area you can manipulate with your endoscope, and if that is large enough, you can calculate and then see, yes, we can use one single burr hole and then perform ETV and aqueductoplasty at the same time. Because of time, I don't know if this will work. Because I see I missed the sliding of it to speed up the surgery time. So I'm still not sure if this video is working. Yeah. Well, I think this is really the only indication for aqueductoplasty nowadays. So usually we say the aqueduct is closed. If you look with an endoscope, there's always a pinpoint opening through it. And initially, that was in the early 90s, we thought that just opening that aqueduct with the balloon, if you see that at the end, you say, no, we have an open aqueduct, that's fine, we leave it that way. Well, 100% of them close up in short time again. So somehow you need to keep this open. Here you see that already the ETV had been performed, but then you can pre-calculate the length of the catheter, you make some additional holes, and then you know exactly how far you put that catheter inside, so that some holes, as you can see here, will also be in the third ventricle and also in the lateral ventricle. So that, and then, of course, you fix this. You can see it later on. Because of this wide foramen of Monroe, we were able to rest that catheter more or less on the choroid plexus. And then you place a reservoir to fix it to the burr hole. That's the way we do aqueductoplasty now. So always leave a stent. And as mentioned, you make additional holes, but you calculate the length of that catheter. Now it is good that these catheters are so long, because usually you only need 5 centimeters, but here you need more. And that's the immediate post-op time. Cystic lesions, yes, of course, we see them more in kids than in adults. Navigation is an really great help in approaching them, because if you enter a cyst, you don't see any anatomical landmarks. So it is much easier to really calculate, just only to calculate the approach and the entrance, to find that little spot where you can do the cystostomy towards the ventricular system. There are some other little tricks that you can use if you don't have navigation, and that is rinsing a little bit so that you can see where the wall is moving, because white matter is not moving, but the cyst wall is moving. In the very young, it is advantageous if you have electromagnetic navigation, because then you don't need to fix the head, you can just turn the head as much as you need it. But that is, it's essential more or less to find the area you want, not to get into the cyst, but to find the place where you open it towards the ventricle. Same with velum interpositum cyst, and finding this place is not difficult, but in that cyst, where will be the contralateral frontal horn? So therefore, navigation, if you have some, otherwise you really have to calculate, especially in these midline cysts, there is not a lot of brain shift, fortunately. So in such a case with the cyst, and that's and they nicely collapse. Actually, they really do. Same with these supracerebellar cysts. We thought, well, we don't need an ETV, because if we open the cyst, the aqueduct will open up. But in reality, while the cyst collapsed, we needed an ETV, because you see here, the aqueduct didn't open. So it was not only compression of that area. So this is what you have to realize. And then these complex hydrocephalus cases, well, that would be a whole extra lecture on that. But these are really difficult cases. This is a stepwise. Complex means you can never solve the problem with one single procedure. This needs multiple procedures, because often when you see them, it's still a developing disease. So for these kind of lesions, you need image guidance and somehow to do this. And then finally, just a short remark on tumors, either doing a biopsy through an endoscope with working channel, but rarely you can remove a tumor. Tiny little tumors, I can only remember a really tiny ependymoma at the aqueduct that we could remove, but usually that is not possible. But if you try to endeavor that, the solid lens scopes are much better for this than the fiber optic endoscopes. And especially because these tumors are often in odd locations, sometimes somewhere in the lateral ventricles. Again, image guidance is really important. Just the trick, it is avoid pre-sampling coagulation, because otherwise you send in coagulated tissue to the pathologist and they will not be very happy with that. I often, in the beginning, received then these reports from the pathologist. Based upon the tiny specimens we received, we think this could be, and so on. So we think that we make big biopsies, but that is the magnification of the endoscope. And afterwards, and that is for all endoscopic procedures, avoid endoscopic tourism, because you love to see all the anatomy. But it is going in, do what you wanted to do, and go out again. That's really essential with endoscopy. And then finally, these endoscope-assisted surgeries. In kids, this is also possible. The youngest we did with craniopharyngioma was 5 years old. 5. He just became 5. So that, because then the sphenoid sinus has already developed a little bit, not very much. These are usually pre-cellar types then, but it is possible. And the nose is flexible enough to do an endonasal endoscopic approach. Well, some are very large, but you still, if that is in the line, so this is in the direct line, and some of them are really big. And I remember one case that we did a live surgery during a workshop in Mumbai, and as it was planned, just an acromegaly and a pituitary case, but then this kid came in, and indeed sometimes in India you see huge tumors, much larger than we normally see them. So they placed an external ventricular drainage, and then the case was scheduled the next day as live surgery. That was not a wise decision to do, actually, because the surgery lasted 11 hours. Amazingly enough, at 9 p.m. at night, there still was nearly 80% of the participants were sitting in the room. That was incredible. And the immediate, still the EVD was there, and this was, yeah. And lastly, I will not.
One day old.
Well, somebody is okay. That is another field, that is endoscopy for craniosynostosis in my department. That has been developed in the past 17 years already, and especially by Erik van Lindert and Hans de Leer. But I will not address that. But that is in pediatric neurosurgery, especially for the non-syndromal part. That is good. Now I will skip this because of the time and come to my conclusions to say that in pediatric neurosurgery, endoscopy is certainly already indispensable tool for cases with hydrocephalus and cystic lesions. And I think that what we see with the craniosynostosis and also the tumor surgery, that is still in a developmental phase, but still at a promising level nowadays. So I hope that you are still awake and because for some it will be very early in the morning, so for some a little bit less. And I thank you very much for your attention.
Andre, thank you very much. That was an absolute masterclass. Perhaps I'll ask you just one quick question. With the endoscopic transsphenoidal approaches, would you suggest that we leave those to skull-based surgeons, or do you think it falls within the gambit of pediatric neurosurgeons to learn?
I personally, I would say that also pediatric neurosurgeons, at least, I don't know how it is with you, but these tumors are operated by pediatric neurosurgeons. from the craniotomy side. And I think if you want to deal with craniopharyngioma, which is more common in kids than in adults, of course we see the adults. It's a second peak in the 50s and 60s age group. But I personally think that it is possible. The question, however, is, will you reach the critical mass of cases that is needed to keep a level of experience in doing this? Yeah. So that's so personally, I would say that oddly enough, I see that here in the Netherlands that endoscopic endonasal, especially pituitaries, is often the second specialty of the pediatric neurosurgeons. It's in the 5 centers that still operate on pediatric neurosurgery. All the pediatric neurosurgeons also do all the cases of pituitaries. I don't know why this combination is here in the Netherlands. It's odd to see, but that's apparently somehow for them it feels as a good combination.
Sure. Thank you very much, Andre. Like I said, that was an absolute masterclass. Claire, can you please confirm that I'm sharing the holding slide at the moment?
At the moment, no.
Okay, let me do that. Okay, now?
Yes.
Okay, great. All right, so I'm going to go on to introduce our next speaker, is Professor Mohammed Al-Baltaghi. So Professor Al-Baltaghi is head of the neurosurgery department at Children's Cancer Hospital in Cairo. And I had the pleasure of visiting the hospital at the beginning of this year and found out that it's actually one of the largest pediatric neuro-oncology units in the world, performing upwards of 1,000 procedures in children annually. So Professor Al-Baltaghi is a highly regarded pediatric neurosurgeon, having done his fellowship in pediatric neurosurgery at the prestigious Boston Children's Hospital, Harvard University. He also serves on numerous international neurosurgery executive boards, including the IFNE and ISPN. And it is an immense pleasure to welcome Professor Al-Baltaghi to give his talk. So Mohammed, if you can go ahead and start your talk on pediatric brain tumors.
Thanks, Lilwin, for this interesting webinar, and thanks for inviting me. Yeah, I hope the screen is clear. So I will be talking on the tumors in the first 2 years of life, some tips, tricks that could be put in consideration while dealing with such neonates. So as an introduction, these tumors below 2 years of life are not uncommon. That the prevalence is for low-grade tumors among this age. We have to study the epidemiology in the clinical and operative profiles. When these tumors present in kids, they usually have a hemispheric form. As you can see, some of these cases usually present with a large tumor, taking one lobe and causing edema in the other lobe. They could be frontal, supracellular, posterior-parietal, or even intraventricular, which is commonest in the choroid plexus, in the lateral ventricle, or the fourth ventricular tumor. So when dealing with them, we have to have some challenging aspects. First of all, the young age of these children, they have blood loss during the surgery that could limit the procedure. The dilemma about the extent of resection versus the safety and morbidity, whether to remove the tumor total or just to take a biopsy in case of blood loss, the rate of tumor growth, especially in young age, and the associated morbidities. There is usually hydrocephalus or midline on increased tension that needs to be alerted either by shunting or by direct tumor attack to reduce the tension. Usually these kids, when they present according to the tumor site and size. The usual presentation when we faced them was increased ICP and failure to thrive. There should be papilledema, and some could present with seizures, either focal or generalized, and some neurological deficits like motor, sensory, and speech deficits. So when diagnosing, we start with an MRI brain and whole spine together with V contrast. Sometimes CT brain also would be helpful. And there are a series of frameless stereotaxy in case of using an electromagnet navigation system, tractography, and functional MRI to evaluate the eloquent areas. In the early management, we should put in consideration managing seizures and cerebral dehydrating measures in case of increased tension, and CSF diversion whenever possible, which is usually due to ventriculomegaly. Going to the definitive treatment, we have to have an aim of surgery and decision making, and each tumor should be individualized. We cannot generalize the treatment. While choosing the surgical approach, we need to have a safe entry zone, short trajectory to the tumor, due to the tumor axis everywhere, and avoid traversing eloquent areas in such growing kids. Cerebral dominance should be put in consideration, and planning to attack the tumor and the components in the tumor, cystic and solid, whether to go to the cystic part and to the solid, or to reduce the cyst and attack solid. During the removal, either removing it in a piecemeal or a large in toto, or a combination of both. And all this should be decided intraoperatively according to the blood loss. With well-defined border tumors, with a moderate mass effect, sometimes you can achieve, say, total or subtotal excision. However, in some tumors with an aggressive nature, with a high vascularity, extensive mass effect, and proximity to crucial areas, we end up in debulking. And sometimes it's satisfactory for tissue diagnosis and controlling the mass effect. But in extremely vascular tumors with critical stages, we sometimes could abort the procedure and end up in a biopsy only. So I will be sharing with you some of my experience in the Children's Hospital till 2015. We collected more cases till now, but this what I have right now is 70 cases with a male to female ratio 1.5 to 1. 40% of these cases were below 8 months, and the common pathologies were medulloblastomas, anaplastic ependymomas, and low-grade gliomas. Other pathology, craniopharyngiomas, and papillomas. The most common presentation were disturbed consciousness, milestones, and some moderate mass effects. So the histopathology, we started with, in the literature, the commonest were the low grade. In this series, we have the high grade tumors constituting 71%. We'll start with of the tumors which I want to share with you. Supratentorial tumors. This is one of the cases, 15 months male patient with irritability and persistent crying. He presented to us with large head, and this is the images. As you can see, posterior parietal approach was used through this trajectory. I will share with you the video. Small cortisectomy guided by a navigation system. We start first by looking for the feeding vessels of the tumor. Usually when dealing with such small kids, we are concerned about blood loss, and the most important into the dissection way is to move around the tumor in order to get all the feeding vessels and get them coagulated in order to have a smaller or a little blood loss. As you can see, after coagulating the feedings, the tumor vascularity reduces, and then you can remove into pieces with a little blood loss. And usually, coagulation and cutting of the vascular pedicle is the most important. And then meticulous hemostasis should be performed after, and inserting an external ventricular drainage, making sure that the blood, the fluid, and that's the post-operative images. This is another case of a 4-month-old male infant who has this huge cyst and this solid part. You see that midline shift. There was 2 debates whether to put a cyst to peritoneal shunt and then take a biopsy, but since he's 4 months, we decided to go directly for the tumor. After evacuating the cyst, you can see the whole tumor. Again, the tips here is working around the tumor and not going directly inside the tumor. As going into the tumor, you can have a massive blood loss that can abort the procedure in the middle, while working around the tumor, coagulating all the feeders first, and devascularizing it is the most important point when dealing with kids with small age and huge vascular tumors. Is the last to achieve after coagulation, then you can remove the tumor totally, as you can see, and again, meticulous hemostasis is very important. That's the postoperative images. As you can see here, what we had is a dilemma of subdural hygroma and subduroperitoneal shunt insertion then was removed later on. This is another 1-year-old female patient who presented with this temporal mass in the temporal horn. Same technique going into the temporal horn. Here we use the endoscopic assistance where we put the endoscope, find the pedicle, coagulate and dissect the pedicle, the vascular pedicle, and endoscopic assistance was of great help here since we have some CSF in the temporal horn that you can navigate by the endoscope around the tumor. You can identify all the vascular features and also the alignment of the tumor. And once you get the tumor devascularized, you can get the whole tumor out and check again with the endoscope for the hemostasis. This tumor is found to be a meningioma, temporal horn meningioma, one of the rarest tumor. Another lateral ventricular tumor in an 18 months. This is a choroid plexus papilloma. Same technique. You can see that it looks very vascular and again working around finding the pedicle. This is a 10 months old who presented to us after being biopsied in one of the other hospitals, and during the biopsy they had massive bleeding where they aborted the procedure and sent it back to us, and we decided to go directly for, again, direct excision of the tumor. In case of some of the cellular tumor, you can see this huge ependymoma, anaplastic ependymoma. Again, there is no way to put a shunt or to take a biopsy. We have to go for bulking in such 9 months old. 2 years post-operatively after inserting the shunt, you can see the subdural space disappeared, and that's a 3-year post-operative. This is another 5 months baby who presented with this huge cystic solid tumor. Same way, trajectory, and subduroperitoneal shunt inserted. After 5 years, you can see complete expansion of the brain. Desmoplastic astrocytoma with the pathology. Another hemispheric tumor. As you can see, most of them, they present with large and line shift where they considered urgent, and you have nothing except directly attacking the tumor. Sometimes you're faced with that you have to attack the tumor directly. This is an ATRT, which was straightforward case, again working around the tumor. Some of the supracellular tumor could present with a craniopharyngioma. This is a 16 months boy with a craniopharyngioma, huge cystic with a huge calcification in the wall of the cyst, direct attack of the tumor and removal. Some could be small like this in a 2-year female, cystic part. This is a straightforward case again that could be directly attacked. Another cranial, multiple cysts and solid. Going to the CP angle, we use the endoscopic assisted here, going from the left terminal approach, back with the endoscope to the CP angle until removing the whole part of the tumor. And this was very helpful to use an endoscopic technique. Some of the supracellular tumor could be a chiasmal tumor. As you can see in this 10 months baby presented with large head. Here we went through the cyst, right terminal, and then start debulking of the tumor, pyeloid astrocytoma. Not all the optic pathway glioma could be approached surgically, since sometimes there is a visual effect for this case of 1.5-year-old boy. We just took a biopsy to confirm that it is a pilomyxoid astrocytoma, as frameless stereotactic biopsy. Then we started a low-grade protocol chemotherapy. 1.5 year, you see reduction of the size, 2.5 year, almost maximum reduction and control of the tumor. Another similar case of a 1-year female who had a severe visual affection. We start with an open biopsy, just debulking, and then we started the chemotherapy. And you can see after 2.5 years of chemotherapy, complete control of the tumor with preservation of vision. So when dealing with supracellular tumors on optic pathway glioma, we have to take care that not all the cases could be totally excised or removed. Going to infratentorial lesions, with this fourth ventricular tumor, especially in this, I used an intraoperative ultrasound. As you can see, this is the tumor, that's the tenorium, and that's the cerebellum, right and left cerebellum. Going through the dissection and the removal of the tumor, I can also do an intraoperative post-resection ultrasound where you can see the cavity completely removed, right and left cerebellar hemisphere and the TENS. You can still fill the cavity with fluid in order to get an idea about the size of the tumor removed. Usually the intraoperative ultrasound is of great help in such small kids, since the intraoperative MRI would be time consuming, especially if large tumor in small kids. And this is dissection again, working around the tumor, removing the tumor in one piece, and establishment of the CSF flow and aqueduct is very important after the excision of the tumor to see the patent aqueduct and meticulous hemostasis. This was a meningioma in a 1-year-old boy. Still, he is now almost 12 years old. And this was also working around the tumor. Another medulloblastoma. So this is one of the challenging cases of a 6-month male patient who presented with this huge tumor. There was a debate again about chemotherapy in order to reduce vascularity, but we ended up in direct attack of the tumor. Fortunately, it was not very vascular and proved to be denso astrocytoma. Again, posterior fossa tumor. Sometimes we use the endoscopic assisted, just wanted to show in this video that using endoscope, you can identify the attachment of the tumor to the peduncle, and you can easily dissect. That's the tumor, cerebral peduncle, and then you can sharply dissect endoscopic the tumor from the peduncle before the removal. I can just make it fast, and then you work with a patent aqueduct again. Pineoblastoma, straightforward. This was approached in a supracerebellar infratentorial approach. Working here in a pineoblastoma started with devascularization, dissection around the tumor, as you can see, sharp dissection, and then removing the tumor in as a whole. This is a brainstem tumor referred to us for radiotherapy, but when we did a stereotactic biopsy, revealed to be a pilocytic, and further images showed that it's a peduncular tumor where it could be approached and totally excised. So tips and tricks should be a selection of imaging modality and careful studying of tumor relation to eloquent areas. We should have a decision-making during the surgery, not only before. The extent of resection should be rejudged intraoperatively. Careful selection of surgical approach, making good use of all your proper adjuvants, especially the ultrasound and endoscope assistance. Need surgery and meticulous hemostasis is very important. To conclude, a take-home message: improving the diagnosis and management of pediatric CNS tumor is very challenging. Management of tumor in children below 2 years is also more challenging, and is wise to leave tumor residue than to endanger eloquent areas. The majority of pediatric hemispheric tumor affect children less than 2 years of old. Contrary to the literature, our series showed high-grade tumor. The most important prognostic factor remains the extent of resection in such kids, because radiotherapy is limited. Available technology, again, and ultrasound should be tailored to maximize preserving brain functionality in those growing kids. There is usually a difficult way to manage the hydrocephalus and subdural fluid collection, especially in these tumors, and the centers of excellence could positively enhance pediatric neurosurgery in the region. Thank you.
Thank you very much, Mohammed, for covering a very broad topic and giving us you clearly have a tremendous amount of experience in treating pediatric brain tumors. There are no questions, and we're going to have to try and make up a little bit of time. So I'm going to move on to our next speaker immediately. Claire, just confirm that the holding slide is showing again, please.
It's correct, it is.
Okay, great. So our next speaker is Professor Anthony Fagaji. So Professor Fagaji is Professor of Neurosurgery and Head of the Pediatric Neurosurgery Unit at the Red Cross War Memorial Children's Hospital in Cape Town. Professor Fagaji is a prolific author and leading academic neurosurgeon, underscored by the fact that he occupies the Saatchi Chair for Neurosciences in South Africa. He has a particular interest in brain injury, both traumatic and infectious, as well as the neurocritical care of these conditions, and has served on the executive boards of numerous international organizations, including the INTS, ISBN, ISIN, and Global Neurosurgery, so spanning trauma, intraoperative monitoring, pediatrics, and global neurosurgery. So as a result of this, he's frequently invited speaker at international neurosurgery meetings and serves on several advisory committees. So having personally spent nearly a decade working together with Professor Fagaji at the Red Cross War Memorial Children's Hospital, which I will acknowledge some bias, but in my opinion is arguably the best children's hospital on the planet. It is really an absolute pleasure to introduce Professor Fagaji and welcome him to give his talk on spinal cord tumors and intraoperative neuromonitoring. Thanks, Tony.
Great, thanks, Lauren and Kenya. Everyone see me all right? Thanks for that very kind invitation and introduction. And I think one of the reasons that that we have such a great hospital is that you were here with us for a decade. So I'm speaking on spinal cord tumors, and of course, like with all the speakers, we can't do justice to the whole topic, and one would have to supplement this with chapters in books. But that's also the reason why I've elected to focus on some of the more practical aspects of tumor surgery and showing you several cases, but hopefully each of them will illustrate a different point. So firstly, I don't want to go through the
screen. I'm not sure that you're sharing your screen. May just see me.
Apologies for that. I thought I had. Okay.
Okay, great.
Is that right?
Perfect.
You got it.
Yep, that looks better, but just open the talk.
Okay, fantastic.
Okay.
So yeah, so just very briefly in the history, I think there are 3 epochs in the history. One, the beginning, spinal cord tumor surgery was described a century ago. And then the prevailing middle period was characterized by conservatism about spinal cord tumor surgery. And then it really started changing in the 90s, and largely in the New York area with Fred Epstein, and assisted by Vedran Delitis, an incredible neurophysiologist. And Fred Epstein gave birth to just so many interesting insights in spinal cord tumors and brainstem tumors, and trained several other well-known neurosurgeons. And Shlomi, I know, spent some time with Fred Epstein in the New York area as well. And that really changed the modern era. Another person that spent quite a bit of time with Fred was Francesco Sala. And so this is one of the papers that really started to shift the international thinking about spinal cord tumor surgery and the role of intraoperative neurophysiology, in large part because he trained in IOM and then went back to a unit headed by Albino Bricolo, who already by that point had done 300 tumor surgeries, so a very experienced unit. And still, in that environment, the new protocols made a difference. And so it's largely with respect to intraoperative neurophysiology, it revolves around the evolution from somatosensory potentials only to motor evoked potentials, and then from motor evoked potentials to something called the D-wave monitoring. So this is a much more robust wave. So sometimes even when you've lost the motor evoked potentials, as long as you have maintained the D-wave above 50% of its starting amplitude, you can be guaranteed almost that the patient may wake up with a weakness, but that weakness, if that D-wave is maintained, will improve over time and the patient will get back to his baseline. So those are somatosensory potentials. These are motor evoked potentials, D-wave electrode. So I can't go through all the principles, but I wanted to highlight a few of the more important ones. One is the preoperative assessment. So it's important to have a very good radiological as well as clinical assessment of a patient, because that's going to determine both what you expect to find in surgery as well as your surgical strategy. Preparing for intraoperative neurophysiology, the motor evoked potentials, D-wave electrode, if you can get it in. Localizing the tumor, like for any spine surgery, whether using the C-arm or a preoperative tag on the imaging, using ultrasound post-bone removal. Very importantly in children, we these days we never do a laminectomy. We do a large laminoplasty. One of the techniques I learned from Rick Abbott, you can do that very, very quickly, even over 10 levels, using the essentially using every instrument. We use the craniotome. You get it under the lamina, and you very quickly, literally within a few minutes, can take off the whole segment, and then of course one wants to put it back. And then we'll talk about dura opening, finding the midline, how to enter the cord, etc. This is our typical setup. We have the child being monitored, neurophysiologist sitting behind the computer talking to the surgeon being able to see the neurophysiologist screen as well. So a few anatomical aspects. The spinal cord surface doesn't always look very friendly. It doesn't always show you exactly where the tumor is. The goal is to, with the virgin cord, surface of the cord, is to try to find the midline. Now, it's not always very easy. One of the things that Rick Abbott taught me was that you crank up the magnification and you look very, very carefully for little vessels that are diving into the midline. But as you can see with this case, couldn't see that at all. And sometimes the best guess that you have, if you don't have certain neurophysiological techniques that are a little bit tricky to do, is to see exactly where the dorsal root entry zone is on either side. Find the midline, the middle between those two dorsal root entry zones, and find a place where you disrupt the vasculature in the minimalist way possible. Rostral and caudal cysts are very common, and they're very, very useful to try to find the superior pole as well as the inferior pole of the tumor. Okay, so I want to demonstrate a few principles around cases. This girl was an 11-year-old girl who presented to us with neck pain and just some mild sensory symptoms in her right arm and a very mild weakness of C5. But importantly, a slight change in her voice. And like many tumors that we see, she's got a very large rostral and caudal cyst. Got the tumor in the middle of it. It's brightly enhancing. It's most likely going to be a JPA. So it's a benign tumor. You know, you can cure her, but it's very high up and it's ventral. So if you get it wrong, you have the potential of creating disaster, which one wants to avoid. So this is the D-wave electrode. It's got 3 electrodes on it. And we put it caudally to the tumor in the epidural space. We try to get it in the midline. This is having opened the tumor surface. We use an IOUS knife, which is the ophthalmologists use. It's very sharp. Get into the tumor, we take it out. And so this is what it looks like post-operatively. And I think the important thing about this, and these are the things that we've learned with neurophysiology, is that when you look at this, the cord is cleaved into 2, and post-operatively, we could see the ventral pier. So these are the motor columns on either, the ventral columns on either side. Now, if you knew that you were doing this without intraoperative neurophysiology, it's quite easy to be disabled by anxiety that the patient will be left with a deficit. But the key thing about neurophysiology is it's not just about keeping this patient safe and telling you when you have to stop. It's also an accelerator in some senses, that if you're operating on the tumor and the neurophysiological signals are safe and you've got the right signals, of course, then you have the courage to keep on pressing on, regardless of one's concern sometimes about the anatomy, in the knowledge that the patient is going to wake up after the operation and will be able to move his or her legs and arms. And so this was her about 3 or 4 weeks post-surgery. Interestingly, intact posterior columns as well, and no neurological deficit. Staying up in the high cervical area. This is a child operated on earlier in the year. Very unfortunate girl with NF2, and she's got tumors all over the place. Some of which you can see here, the CP angle tumor. She's got this posterior fossa on the floor of the fourth ventricle tumor. That is an ependymoma. This is also an ependymoma. It's high up in the spinal cord. It's intramedullary, and then she's got a couple that are extramedullary as well. So we took her to theatre to take out the spinal cord tumor, the fourth ventricle one, and the extramedullary ones. And this is what the spinal cord tumor one looked like. Again, very difficult to determine where the midline is. Try to preserve the vasculature as much as possible, but sometimes one has to sacrifice some small vessels, and slowly getting into the tumor. And hopefully on your screen as well, you can appreciate the difference in color. So that's where the tumor is. Just skip ahead a little bit. We use the Kuza until at very low power, until you can start appreciating the difference between normal cord and tumor, and then just slowly taking out all the last little bits of tumor. So this was a post-op, it was an ependymoma. Sometimes tumors can be there for a long time. This was a 13-year-old boy with long-standing scoliosis, which was first noted when he was just 1 year, a 1-year-old boy, and only had mild left weakness, left leg weakness, and his main problem was the progression of scoliosis. And this also makes it sometimes very difficult to image because of the marked scoliosis. And so he has a tumor here. You might have to take my word for it because it projects so poorly. And this is one of the difficulties in imaging patients with scoliosis, getting a decent midline image. This is what the tumor looked like operatively. Little bit of staining on the surface. And you can see a lot of gliosis around the surface of the tumor once the tumor had come out. Very, very long-standing. Very important about many of these tumors in children is that they are benign tumors, and often they can be there for a long time. And there's a huge amount of potential to create surgical morbidity in a benign tumor, and that's absolutely something that one has to avoid. So that's just post-operative imaging, and this was in clinically. Now moving down into the thoracic spine, this is a 5-year-old girl with mild scoliosis, no obvious neurological deficit, but a very long and wide tumor. So we know it's most likely going to be a benign tumor, but always very anxious because the child is, apart from very mild scoliosis, completely well. It can be intimidating sometimes to look at the axial scans because it can be difficult to see a clear plane between tumor and normal tissue. And this is what it looked like opening it up. We open the dura in a blunt way, open up across the whole length of the tumor. You can see there's one part where it was presenting to the surface. And then just slowly and systematically sucking out the tumor using the Kuza on low power until all the tumor is taken out. And usually I close the pier and we put a big dural patch on the over the dura, and then we put the bone back, of course. So this was a polymyxoid astrocytoma, the tumor's out. That's what she looks like post. So again, even if they're large tumors, if one's just working systematically and there's a reasonable plan and you respect the rest of the tumor, one should expect very good post-operative results clinically. And then also here in the thoracic spine, a little less discrete, perhaps, certainly in terms of the enhancement. But again, you're expecting a benign tumor. This is just once again putting in the D-wave electrode. You create a bit of space in the epidural, the epidural space below the tumor. You secure the D-wave electrode, and it stays there for the rest of the operation. I'll just skip ahead so you can see the tumor coming out. That's a post-op. But so that's largely what we see. But I wanted to mention just in closing a couple of deviations. One, so some patients that with tumors that don't enhance very well, especially in young children, you come across gangliogliomas, and sometimes they rotate the cord. And so this is a cord is completely rotated. So of course you can't get into the midline. And so this one we had to do skip lesions across all the dorsal roots. So these are the roots, the contralateral roots coming over to that side because the cord's rotated. So can't always get into the midline. Sometimes when you run into problems with intraoperative neurophysiology, so this is the baseline, this is the current, you'll see it drops out here. So you stop, you wait, you irrigate, you see if the signals come back. If they do, you continue. If they don't come back and you've waited long enough, sometimes you've got to pause and come back another time. So sometimes what we'll do is we'll come back 4 or 5 weeks afterwards. If the intraoperative neurophysiology was unstable, it's often reset itself. The cord's developed a bit of tolerance and you can carry on. And then just very lastly, this is a child with an ependymoma who presented to us in an acute way with a tumor bleed. So that's the first thing that told us that something is different about this kid, that tumors don't usually bleed. If they bleed, it's telling you usually that there's something afoot. This was an ependymoma. We took out the tumor. The child was fine. We started focal radiotherapy. 3 to 4 weeks later, the cranial imaging was completely normal. The CSF was normal as well. But then 3 months post-surgery, she presents with a left facial weakness out of the blue. Her spine is still fine, but when you look at the facial nerve, she's got tumor there. So we converted to craniospinal radiotherapy, but still 7 months down the line, she's got all this leptomeningeal disease, and she in fact presented with extra CNS disease in the chest as well. So it's not always like I explained with benign tumors. But in summary, most of the tumors are benign and they can be cured. And this is really, really important because their survival is 95% to 100%. So there's very, very little tolerance for surgical morbidity. And it's important that we as surgeons have the surgical experience. And if you don't have the experience, then get help by somebody who has more experience or refer the patient to a center that does. Often there isn't a clear plan, but most tumors can be completely resected. And for us and many other places, intraoperative neurophysiology has been important in making decisions. But it's not just a handbrake, it can actually be an accelerator. Knowing that the IOM is stable can continue to get a more aggressive resection. And very last is no harm in coming back if the neurophysiology is unstable. And we've done that rarely, but successfully. Thank you very much.
That was really a great talk. It's nice to see that the experience is growing with these things, and I agree with you completely. These complex tumors should be referred to higher volume centers with the necessary expertise. So we don't have any questions. I'm going to.
Can I have a?
Yeah.
Can I make a remark?
Sure.
It's Dr. Martinez from Rensburg speaking.
Yes, Martinez. Thanks so much. Yeah.
Yes, I can just a bit of history. I can just remember a professor from Rensburg telling us in our early days in neurosurgery when I was there in 1988 onwards that actually in Pretoria we were one of the first units in the world that started with removing intramedullary tumors in the pediatric patients. And he said with a smile, and I think Dr. Jacques Duplessis will also confirm that most of the rest of the world didn't believe us then that we could remove them. We didn't have intraoperative monitoring at that stage, but we could remove the tumors very successfully. And what was incredible as well, multiple level thoracic tumors removed successfully, and even the dorsal columns intact afterwards. That was always amazing to see. with surgery with a microscope and ultrasound dissection and removal.
Thanks so much.
You.
Thanks for sharing that. Yeah, just a testament to the surgical skill of Professor van Rensburg. So thanks to all our speakers. I mean, that was really a fantastic program. Thanks for taking the time to do that. We're going to move on to the latter part of our program. So I'm going to ask Dr. Jacques du Plessis. So Dr. du Plessis is a senior, highly respected neurosurgeon currently in private practice. He was one of Professor van Rensburg's proteges and earliest trainees. So he's going to talk to us and tell us a little bit of background about Professor van Rensburg. Jacques, you want to get started?
Morning, Llewellyn, faculty members, colleagues. It's a great privilege to tell the audience more about Prof. Ozzy van Rensburg. Prof. van Rensburg matriculated in 1947 at the age of 16 years at Maritzburg College in Pietermaritzburg and was a top student in Natal that year. He completed his undergraduate studies in medicine at the University of the Witwatersrand, cum laude, in 1953 at the age of 22 years. He had always put a great premium on the basic sciences, and after his internship, he became a lecturer in anatomy at Wits for 2 years. He then moved back to Natal and became a registrar in general surgery at Edendale Hospital, where he completed his studies, and he became a fellow of the College of Surgeons of South Africa in 1962. And he obtained an FRCS in Edinburgh the following year. He then worked as a registrar at the Department of Pathology at Wits for a year, and he only then decided that his foundation was solid enough to pursue a career in neurosurgery. He had always wanted to become a neurosurgeon right from the beginning. He obtained a post as a registrar at the then Johannesburg General Hospital, where he trained under Drs. Lua Allen and Healy Mendelow, the father of David Mendelow, who is currently the head of neurosurgery at Newcastle upon Tyne. And he became a fellow of the College of Neurosurgeons of South Africa in 1966. He stayed on as a full-time lecturer at Wits until 1970, when he went into private practice at the Princess Hospital in Johannesburg. There was a unique setup where the private sector and the public sector were integrated in the training of undergraduate and postgraduate students in neurosurgery. He performed most of the intracranial surgeries in the Johannesburg region those years, as he had the support of almost all the neurologists in Johannesburg. Unfortunately, many of the neurologists decided to emigrate when the political unrest started in 1976. He then had job offers from the US and Australia, but he declined it. Prof. van Rensburg was not interested in spine surgery, which unfortunately was and still is the bread and butter of most neurosurgeons in private practice, and he was headhunted by the head of the Department of General Surgery at the University of Pretoria and appointed as head of the Division of Neurosurgery in 1978. Neurosurgery became a separate department, and he was appointed as the first professor and head of the department in 1984. He was a close friend of Prof. Ghazi Yassagil and regularly spent time in Zurich in the 80s. Prof. van Rensburg was loved and respected by his peers and his registrars. He devoted his whole life to neurosurgery. He had a profound knowledge of surgical neuroanatomy and functional neuroanatomy. His office door was always open for his registrars, and he was always available to give advice. He was an excellent clinician and respectful to everybody. He was a meticulous surgeon and trained each of his registrars personally, spending hours in theatre and guiding us through neurosurgical techniques, from the most basic to the most complex procedures. His favorite phrase while watching through the teaching scope, if one of the registrars operated and things went well, was, "That's my boy, now you're cooking with gas." He had excellent clinical judgment, and he was in a class of his own when it came to academic knowledge of the neurosurgical literature at that time. He could interpret pathological slides as good as any pathologist. He trained approximately 50 neurosurgeons, many of whom now practice overseas. We were all part of a big family. One of the highlights every year was when he and his wife, Lucia, invited all registrars to the house for dinner. Both of them knew every registrar and his or her partner personally. Even Lucia knew each of us and our partners by name. Neurosurgery remained his passion, even after his retirement, although he also enjoyed fly fishing at that stage. He was appointed as a consultant in the department after he retired, and Prof. Mokgong took over from him, and he remained focused on the training of the registrars. He still did ward rounds and spent hours in theatre in an advisory capacity until approximately 4 months before he passed away at the age of 83 years. It was my privilege to train under him and to be a full-time consultant in his department for 2 years and a part-time consultant for 12 years. Prof. van Rensburg has left behind a legacy of neurosurgeons who will remain grateful to him forever. Thank you.
Thanks so much, Jacques. It's always heartening to hear the perspective of trainees from some of our previous mentors. Thank you very much for that. I'm going to ask Dr. Tobejani to introduce Professor Mokgong. Just briefly, Dr. Tobejani is a neurosurgeon in private practice, specializing in spinal neurosurgery and pain management. He graduated under Professor Mokgong and will give us an insightful perspective on Professor Mokgong. Thanks, Emmanuel.
Thank you, Prof. Just if you can get out of this thing. I'm not sure if the screen is sharing on your side.
No, you can try that, please.
Okay. Okay, is it sharing now?
It is sharing.
That's fine. You want to go back one and start again? Yeah, that's it. Thanks, Emmanuel.
Apology for everything. To the organizing committee, in particular, Prof. Padayaki, colleagues and friends, ladies and gentlemen, Dr. Yak du Plessis just almost sensitized us from, especially some of us who have qualified under the leadership of Prof. Van Rensburg, as well as Professor Mokgong, and Professor Shabiro is also in attendance here. It is both an honor and privilege to introduce to you a man who introduced himself to this planet Earth on the 31st of August 1952. He's a father, a husband, and a grandfather. Most importantly, as we present, Professor Mokgong would also like to pay respect to his family for allowing him to share himself with the rest of the medical fraternity. Professor Mokgong was born and raised during the difficult times of apartheid regime in South Africa that was characterized by discrimination, oppression, and unequal access to higher education. He had initially wished to pursue a career in engineering, but he eventually found himself in the field of medicine. He had to navigate through the political unrest at the time and the student protest, but maintaining the focus of finishing his studies and became the first Black South African neurosurgeon at the time. After completion of his fellowship in neurosurgery, he spent 10 years as the head of department at Sefako Makhatu Hospital. The accolade that he was not happy about being the only Black neurosurgeon he took a conscious decision to deliberately and systematically make it his personal mission to develop and train Black neurosurgeons that up to date in his 20 years of professional career, produced over 20 Black South African neurosurgeons, amongst the list being the first Black female neurosurgeon and the youngest neurosurgeon in the continent produced under his guidance. Some of the career moments from Professor Mokokong was his sterling opportunity to work in the Craniopagus twins. But most importantly, he also received some multiple awards and merits for his stellar job in developing neurosurgery. Of note, in 1999, he received the Order of Merit for Outstanding Contribution from the Executive Reserve Club. In the year 2000, he received the Onkgopotse Tiro Order, which is one of the highest from the University of the North, and was awarded the Emeritus Professorship by the University of Pretoria, where now he headed the unit for 10 years, again being the first Black head of Department of Neurosurgery at the University of Pretoria. He, as a leader, he has occupied some instrumental positions and led multiple organizations. Of note, being the acting dean at Sefako Makgatho, as well as the interim dean during the transition or the merger of the University of Limpopo. He established the intensive care unit at Sefako Makgatho Hospital and became its first head of department in 1995 to 2000. Towards his later years of practice, he was elected the President of Health Professional Council of South Africa from the years 2010 to 2015. Ladies and gentlemen, these are some of the moments of Professor Mokokong, the man who enjoys traveling a lot in the world, and a staunch Orlando Pirates supporter. Most of the time when we come to his offices, we find him with newspapers. And as the saying goes from Dr. Du Plessis, when he said, for Prof. Van Rensbeck, he used the phrase, "That's my boy when everything goes well." But for Professor Mokokong, he used to say, if the mountain cannot come to Muhammad, then Muhammad will go to the mountain, signifying that he had to bring neurosurgery services to the underprivileged services by establishing neurosurgery units at Kalafong Hospital, which were not there, as well as the Witbank Hospitals and Tembisa Hospital. He's now a retired professor, but currently still doing elective work at Tembisa Hospital. Ladies and gentlemen, we present to you Professor Mokoko. Thank you.
Thank you very much, Emmanuel. And it's always educational, I suppose, just getting a perspective on the historical background of a lot of our departments as it fits into the context of South African history, which is often quite complicated, but I think incredibly beautiful. So it's quite nice to celebrate these. We are privileged to have Professor Mokokong with us. So I'm going to ask him to just use this opportunity quickly before I introduce our speaker. Professor Mokokong, can you say a few words? I know he was having some trouble with the audio. Okay, we'll try again maybe after the oration. Claire, can you hear me, just to be sure?
Yes, I can.
Okay, and are you seeing the holding slide?
Yes.
Okay, so we're running a bit late, so I'm going to try and make up for time a little bit. So you've seen the context of why this oration was conceptualized and its context in this sort of in the history of this department, and looking for an appropriate orator who has distinguished himself and has an international presence to establish the prestige of this talk can be quite a daunting task, but for me wasn't that difficult. So I'm going to introduce Professor Shlomi Constantini. Professor Constantini is full clinical professor at Tel Aviv University, head of the Department of Pediatric Neurosurgery at the Dana Children's Hospital, and director of the Gilbert International Neurofibromatosis Center in Tel Aviv, Israel. Professor Constantini did his training at Hadassah Medical Center in Jerusalem, then subspecialized in pediatric neurosurgery, completing a fellowship under the legendary Professor Fred Epstein at New York University, like we heard from Tony previously. Was quite a sort of mecca for intramedullary spinal cord surgery and monitoring. Professor Constantini has held several leadership positions in international neurosurgery organizations, including past president of the IFNE, past General Secretary of the ISPN, Congress President of the 2018 ISPN meeting in Tel Aviv, which is reputed to have one of the best meeting attendance in the organization's history. He was also past Vice President of the EANS. Professor Constantini is a prolific academic with over 300 scientific publications, has been invited international speaker at innumerable neurosurgery congresses. He is without a doubt one of the world's leading figures in pediatric neurosurgery, underscored by the referral of complex pediatric neurosurgery cases from across the world. And he always serves as an ambassador for our specialty wherever he goes. He's trained numerous fellows from all over the world, all of whom speak extremely warmly of him and fondly recall his paternalistic mannerism with them, which in my opinion probably says more about the man than any of his other accomplishments, and swayed my decision to invite him to give this oration more than anything else. So with that, I want to invite Professor Constantini to give us the 2020 Van Rensburg Mokokong oration. Thanks, Shlomi.
Thank you, Llewellyn. I hope that my screen is shared well and that you hear me well.
Yes.
Yep, both of those. Yeah.
Thank you. This is fantastic to be affiliated with Africa, and especially with the Cape Town school. Hi, Graham. Hi, Tony. Hi, Llewellyn. Hi, my friends from Africa and from all over the world. This oration is coined, incision is less important than decision, or what we have changed in the last 25 years. I also like the coin, low tech is more important than high tech. So I hope to intrigue you with a little bit with this oration. President Kennedy visited the famous prison in Alcatraz. So they took all the inmates together in one room. He did not know how to start his speech, so he said, I'm happy you're all here. So this is how I'm going to start my talk. I'm happy you're all here. I want to show you this case. This is a 10-year-old that came with headache and papilledema. An MRI showed a posterior third ventricular tumor with hydrocephalus. We did an ETV. The day following the ETV, the girl is asymptomatic. You see the nice flow void at the floor of the third ventricle. What to do now? She's asymptomatic. So I did what I do very often. I consulted my friends around the world. Neurosurgeon number one, my trainer, Fred Epstein, said, wait and see. Number two said, in a more cowboy way, take it out. Number three in Pittsburgh said, I can do a stereotactic biopsy. Another one said, irradiate and see. Another one said, give chemo and see. Another one said, redo endoscopy. And one more operate. So 7 esteemed neurosurgeons, pediatric neurosurgeons, had 6 different ideas what to do. Now, who should make this decision? Is there a right choice? So I see many patients who come to me with a second, third, fourth opinion. I try to preach them to choose a doctor and not to choose the type of treatment, because you can be lost with so many options that exist out there in the modern world. And this is my trainer, Sir John Graffelder, said you can teach a monkey how to operate. You cannot teach a monkey when to operate. And also, you cannot teach a monkey when to stop the operation. This is my country, Israel. It's a small country. This is Tel Aviv. And when I prepared this lecture first, I gave a different version in India. So I prepared a little bit about global pediatric neurosurgery. Thank you, Graham, today for helping me. So this is our BB, and this is the place in India where I gave this oration first. And this is when you superimpose Israel on the map of India. This is when you superimpose Israel on the map of the United States. And this is huge Africa. So If you look at the square kilometers, Israel is 20,000 square kilometers, India is about 3 million, and Africa is about 30 million. If you look at the birth rate, in Israel we have 170,000 births per year. In India we have over 18 million babies born per year, and in Africa we have close to 40 million born per year. So obviously Africa and Asia is taking over in terms of new children coming in, and this made me think about pediatric neurosurgery a lot. This is the life expectancy, by the way, comparing Israel and India, and you see in Europe 75 for men, 82 for women, and this is in Africa. It's still low, but it's coming up very nicely. So acknowledging that most children are born in Asia, in Africa, we put this cover on the March 22 Child's Nervous System, showing basically, I hope you can see my arrow. These are the children who need care. This is the facility. There's only about 10% overlap. And this is what we're doing now, and the organization's trying to push these two circles together so that the overlap will be bigger. This is the Tel Aviv Medical Center, the Dana Children's Hospital. This is our desk, and please come to visit us at the Dana Children's Hospital. We are a very international department, as Llewellyn mentioned, including several graduates from Africa. So what I want to do today is speak to you a little bit about decision under no data cloud, the concept of DID, delayed diagnosis of pediatric brain tumors, a little bit about technology, a little bit about incidentalomas and vomit, when not to operate, when to stop surgery, when MRI is enough to make the diagnosis, and a little bit about the fallacy of informed consent. This talk has no rules, it's philosophy in general. So first of all, who should treat children and why children? Children have different presentation, pathology, philosophy, technical aspects, and preferably they have to be treated in a children's hospital. This is a tribe. We're not treating one person. We're treating a family with the whole cloud around him. Kids are strong. They're strong biologically, they're strong emotionally. This changes a little bit our paradigm of decision-making with children because they can resist a lot more trauma than adults. Adult brain tumor experience is probably irrelevant to children on all these levels, molecular, biological response to treatment. Look, for example, at comparison of high-grade gliomas in children on the higher row to adult high-grade glioma, and looking at three different molecular markers, EGFR, P10, and P53. So the same tumor under H&E staining has totally different molecular characteristics. Low-grade gliomas in children will always undergo malignant transformation. In children, it almost never happens. The growth rate actually in many cases may slow over years. Some may involute. So again, the same tumor under H&E behaves in opposite biological directions. How about response to treatment? This is from the famous Stupp study. Addition of temozolomide concomitantly with radiation makes a difference in adults, makes probably no difference in pediatric high-grade gliomas. And then the long-term effect. This is a summary of a study I will show you later. 4 out of 5 brain tumors that we get are alive 10 years later. So we have to think about the long-term effects and to reduce morbidity. This is, of course, a whole lot of stress on the system. I personally have over 2,000 graduates with pediatric brain tumors with additional 150 to 200 every year. Just imagine each one of them is doing once, twice, or 3 times a year an MRI just to see it and give them a feedback is a huge traffic. This is the first neurosurgical patient, Goliath, with David. It's a story from the Bible. Goliath was a typical case of acromegaly. He had bitemporal hemianopsia which allowed David to shoot the stone right into his overdeveloped frontal sinus. So on the left is how neurosurgery was when I started my training. And on the right, it is now. Get the team synchronized. You have to work with a team. And the first wave of changes occurred with the microscope, with the imaging, and with neuroanesthesia. On the left is the Opti-1. It's a microscope with which I started my training. Now it is used for restoration of pictures in the Vatican. And on the right are the beautiful, beautiful machines that we have now as microscopes. They give us light magnification, total balance, and total integration with our navigation system, plus more advantages. So we work in a team, and the team has several components, and I would like to acknowledge the neuroradiologist first. So we moved on the left from the air cystogram, from the angiogram to the high-resolution MRIs on the right side, and often I wonder, do we see too much? For example, on the right is a patient with NF2. She has all these tumors. Do we really need to see them? We're not going to operate on them. How often do we need to repeat the MRI? How can we compare when neuroradiologists are so hard to find and their time is so expensive? Look at this. This is what we do with chronic tumors. For example, optic pathway gliomas. The neuroradiologist sits offline with a technologist and separates the tumor volume into solid, enhancing, cystic. So when we sit in an oncology meeting, we look not only at the perspective of the last 2 scans, but at the whole perspective over years of what happened, and the treatments superimposed. You can get a much better perspective in order to make oncological decisions. And this, of course, the DTI, the white matter tracking, this is our JNS cover from December 2003. God, this is almost 17 years. The challenge is really to bring those beautiful pictures to the table in order to help patients. And really, the challenge is how to combine the imaging with the physiology, with IOM. IOM, of course, as Tony and others have mentioned, has become mandatory in our operations. So what we did in this study, which is 9 years old, we took the DTI information and then the information from stimulation during the surgery, direct corticospinal tract stimulation, and produced this graph. So simplified, the distance from the corticospinal tract vis-a-vis the threshold for stimulation is 1:1. So if you get a stimulation at 5 milliamperes, you are 5 millimeters from the tumor. We use the electrified CUSA. I beg you, use it. It is very, very simple. An adapter is commonly available. So you don't have to bring in and out a stimulator continuously. While working with the CUSA, you get the responses. This is good for supratentorial. It is also good for intramedullary spinal cord tumor. This is an example. You see this thalamo-peduncular tumor and how close is the DTI of the cortical spinal tract. And this is what we did in surgery. We left some tumor behind. It is fine as long as your patient is okay. I guess in the old days, we would work until we get to the interface, and we would take the child probably hemiplegic or monoplegic from the surgery. So this electrified CUSA, in my eyes, is one of the most important revolutions of the last 5 to 10 years. These are pediatric brain tumors where there is no need for biopsy anymore. The tectal tumors, we know to identify them. We perform an ETV, we follow them. The hypothalamic hamartomas presenting as precocious puberty or as intractable seizures, they're so typical, you don't need a biopsy. This is an optic pathway glioma associated with NF. No need for biopsy. Of course, the notorious diffuse pontine gliomas. The double tumors, they're always germ cell tumors. and also the tuberous sclerosis associated SEGA. So we have moved forward with the ability to identify tumor and maybe prevent a biopsy. And we also have convinced our partners, the oncologists, that in some patients, a biopsy or histological verification is not mandatory to proceed with oncological treatment. Well, the anesthesiologists are also important. I hate to say that. They've moved a lot forward. Long operations, relaxed brain, blood replacement, and metabolic control. There's a camera in the lamp, and as you know, infants especially, they can stop immediately. Unlike an adult, which goes gradually into shock, an infant will go to shock and arrest within minutes. Look at these examples. I think that Muhammad have shown some of these. This is a 2-month-old with a typical teratoid rhabdoid tumor who bled 7 body volumes during surgery. At the low side is a 1-year-old that came with this non-specific tumor. She bled 5 body volumes during surgery. She's now 7. She's actually now 11, and she's totally well. You cannot do it without 2 or 3 anesthesiologists standing there and helping them while you fight with the tumor and the tumor vascularity. Even craniosynostosis can be very challenging from the point of view of bleeding. So you need your anesthesiologist to be trained, understand the surgery, give replacement as needed, and be in touch with you a minute by minute. Navigation during surgery is difficult. It is more difficult than it looks on the MRI. We have evolved from the nice stereotactic frames, as we all know, the CRW, the BRW, to the navigation machines. Well, the navigations are nice. We do them now. We have the infrared cameras connected to the antenna so that while we look through the microscope, we know exactly where we are. Well, we know the trajectory, but this is based on all the imaging. If you look at the picture of the MRI on the right side, you see that the brain is moving. Whilst you open with a craniotomy, the whole perspective is changing and your old navigation becomes useless. It took us about 10 years to acknowledge that. Look, also the midline structures are moving. Not only the surface is moving. So we had to get something that has to do with real time. And this is the Polestar from Odin that came to our service in 2004. Well, it is a pain, I have to tell you. It is quite coupe. It is small. You don't need to change all the equipment. You can have it at the down place, mid place, up place. The pictures are not that great. They're certainly not as great with the high Tesla machines that are available, but it is much more easy to use. And you see here, you can see the needle taking a biopsy from a tuberculoma on a 15-year-old boy. Well, the IMRI is expensive, too much pain. We needed something more down to earth. And this came in the form of the Sono One, an ultrasound-based real-time intraoperative imaging and navigation. I would like to encourage those who don't use it to use the ultrasound each time you open the dura. This is true in cranial surgery and in spinal surgery. Look at those magnificent pictures that you get. On the left is an MRI. On the right is an aligned ultrasound. This is true, of course, only after you open the bone. Technology is expensive. It breaks. It creates accidents. It may mislead you. It creates dependency, and it introduces options. And on the left is the Inca. On the right is our operating room. 20 years ago, we had already the navigation, the microscope, even the monitoring was there 25 years ago. And this is now, this is a picture. This is my partner, Jonathan Roth. I counted in the room 19 monitors. We are perhaps overdoing it. As you know, with every new innovation, you're first very happy, then you go into depression, and then you stabilize somewhere in the middle. So common sense is much more important than technology. And perhaps what is really important is to adopt the technology to a specific patient. And on the right side, you see a 15-year-old with a tectal tumor. This is actually the first ETV I did in 1994. This is classical for an ETV. So you have to have the capacity to perform endoscopy, as Professor Grotenhaus has told us very nicely. So we have better imaging, we have interventional neuroradiology, the endoscopy is fantastic. The electrified CUSA is a must. We have also better chemotherapy. I will show you an example. We have much, much better radiotherapy. Not only the protons. I personally think that radiotherapy is underused in pediatric neuro-oncology. And we know better when to avoid surgery. Unfortunately, despite all this availability of MRI, many patients come in late, what we call delay in diagnosis. And as we know, prevention is far more effective than treatment. So we published these two papers on delaying diagnosis of pediatric brain tumors and delaying diagnosis of primary intradural spinal cord tumors. A shocking number are being diagnosed late. About 50% of the children, this is on a series of 330 tumor cases in children, 50% come in late, and half of them, 27%, come in what we have defined as unacceptable delay. This paper has been published in Child's Nervous System. Interestingly, about half of them will have a normal neurological exam, and only 1 in 5 will have papilledema. So, some symptoms: headache. Headache alone is very, very seldom a sign of a brain tumor. Of course, when headache comes with vomiting, it is pathognomonic for a posterior fossa tumor. When you look at headaches alone, this is a series from my hospital. Before I came there, 300 children with chronic headache, but nothing else. None of them had a brain tumor. So it depends if you're a primary care physician or whether you're at the end of the referral tube. So always remember, the pediatricians, the pediatric neurologists have to handle a very large number of children. So what we did, we put on the YouTube this short clip. Just go to how not to miss a pediatric brain tumor, and you will find it. It's in 6 languages, and I think we can make a lot just by distributing it to our pediatric neurologists, to our pediatricians, to know the markers of brain tumors that should make you a little bit worried. It is only 4 minutes. Okay. Neuroendoscopy was described by André Grotenhuis. This is the principle. You make a hole here, and this is how we do it. I will skip it. I just want to mention, and this is the case, the first case I did, and this is already 26 years ago. You see the nice flow void. This boy never had any surgery since then. But endoscopy has revolutionized the way we treat posterior third ventricular tumors. We do an ETV and we take a biopsy. This has 2 implications. The first is that the pediatric neurosurgeon needs to be able to do it. And second is that the experience of removing pineal tumors, for example, is diminishing and has to go to a sub-specialized centers, similar to the comment that Llewellyn had about intramedullary tumors. Of course, you have to do an ETV and a biopsy. You can do it by 2 goals. You can do it by 2 separate bell holes. You can compromise, or you can do it with a combination of rigid and flexible scope. This was published in Journal of Neurosurgery quite recently. So decision-making is extremely difficult to do when we're dealing with a rare pathology with such a diverse pathology. This is the beauty of our profession, but at least half of our patients are weird. We've not seen exactly the same tumor, and we need to struggle with the decision. Remember, our experience is mainly learned from our failures. And The new technology provides us with a lot of options we have to decide. If you take 4 types of pediatric brain tumors, the first one is a medulloblastoma. They go for surgery, oncology, and follow-up. Second type is a classical pilocytic cystic astrocytoma. They go for surgery and follow-up. The third one is a DPG, no surgery, oncology, and follow-up. And fourth type, this is a neurofibromatosis case with a small tumor. They go for follow-up only. What is common for all these cases is the follow-up period, and it is during the follow-up period that you learn most about your patients. Another concept, combination treatment. This is a tactile tegmental tumor, cystic astrocytoma. I operated on her. We gave her chemo. We gave her focused radiation. She is fine, just fine. This is how to combine surgery, radiation therapy, chemotherapy, and doing nothing is an art that has to be practiced and has to be thought as an art, not necessarily as science. Well, do we know better to talk to our patients? I'm not sure about that at all, but I want to show you actually the last case and then I will stop. This is a 5-year-old boy with a funky CV junction intrinsic tumor. This is not the cervical medullary tumors that Fred Epstein has described. I took him for a posterior fossa craniotomy, a C1 laminectomy. The pathology was a ganglioglioma. This is what you see. The tumor comes to the surface. This is the midline over here. I did a Moses resection. You see here the residual. This boy has been stable for 5 years. This is the volumetric assessment, stable for 5 years. And then after 5 years, he started to progress. You see here, the enhancement is progressing. The T2 changes go all the way to C6. At that point, he's still asymptomatic. What to do? I was not very keen operating again. My friends in the US suggested to irradiate him right away before he starts having problems in eating, breathing, swallowing, etc. What we did is give him a BRAF antagonist because he was BRAF fusion negative, but V600 mutation positive. So look at his tumor and look here what happened. This is before the dabrafenib treatment, and this is after. 6 months later, tumor almost disappeared. Look here and look here. Well, this is the best remarkable response to dabrafenib, and these are the whole new drugs of BRAF inhibitors and MEK inhibitors. And if you want to educate a little bit about brainstem tumors, look in the YouTube under the listserv or in Acta Neurochirurgica. I think I will stop here because time is outside. I thank you again for the invitation. Thank you very much for holding with us.
Thank you very much, Shlomi. That was a fantastic talk. Thanks for setting the tone and standard for this lecture, which we hopefully will run on an annual basis. And there's no doubt that we couldn't have asked anybody better to inaugurate this lecture series. So I've got a message from Professor Moko Kong that he sorted out his audio issues. So it would be nice to just ask him to make a comment. Professor Moko Kong.
Hello, Llewellyn. Can you hear me?
We can hear you, yeah.
Oh, yeah. Can you hear me?
Yep, we can hear and see you.
Yeah. Yeah, sorry. I'm sorry about the problems I had, but make no mistake, I have listened and looked at all the presentations. So my problem was just to get connected to you. Hello?
Yep, we can hear you.
That's correct, yeah. So, okay, let me just, now that it's late, let me say a few things. Firstly, thank you, Dr. Tobejane, for the kind words that you have said about me. Secondly, let me pay my respects to my mentor, the late Professor van Rensburg, whose department I had to run later. He's always been my mentor, even when I was training, and he was responsible for putting the icing at the top of my training. He also was responsible for making me go to Vet University for the exposure there. So I would like to pay my respects to him. Now, also, you, Llewellyn, as my successor, I want to say I'm very happy that I know that the department has been left in good hands through your diligence, through your hard work, through your academia, through your international connections. I'm sure our department is left in good hands. Now, finally, to all the people I produced, to all the people I trained, I, as a Christian, would like to thank God that I had the opportunity to produce as many neurosurgeons as I have on that great platform. So, Llewellyn, all of the best, my friend, in future, and keep the fire burning. Thank you very much. Hello?
Yes. Thanks, Professor Mokokong. It was really great that we had the opportunity to hear from you and some of your experience with Professor van Rensburg as well. And it's been a real privilege to sort of take over and try and keep running things in that order. I'm going to just skip to our end here. I want to thank firstly the University of Pretoria and then Europa Organization and Life Healthcare for their support of this educational initiative, and then all our esteemed faculty, thank you very much for taking time, the attendees for staying. I think a lot of attendees stayed right to the end. We did overrun time a little bit, but thank you very much.